Good morning, my name is Ágata de Baginha and I work for GAT, Grupo de Ativistas em Tratamentos. I'm presently a nurse in a project called GAT Afrique, focused in immigrant population, people that come mostly from sub-Saharan Africa. And during the COVID-19 epidemic, for a period of time, I was supporting the activities of another project where GAT participates called the PCVM or the DCR, Drug Consumption Room, which is a mobile clinic for people that use drugs and that provides a safe space for people who use IV drugs, avoiding infections, skin infections, transmitting infections, and then also providing care in case of overdose, among other services. So I was invited to present to you this a little bit of the GAT history, epidemiologic background on the HIV situation in Portugal, more or less the services that we provide, and more specifically, how could we adapt our activities to keep providing services during the COVID-19 epidemic. So, giving you a brief presentation about the epidemiological situation of HIV in Portugal, I would say that in the last years, the number of new diagnoses has been diminishing, so is reducing, and we were able already to achieve all 3 HIV targets set by the UNAIDS. So, we have now 92.2% of people living with HIV already diagnosed, 90.3% of people who are diagnosed with HIV already into treatment, and 93% of people into treatment achieved already the viral load suppression. Our path now is to walk towards the 95 units targets, and of course in the direction of zero discrimination. Basically, GAT is a non-profit or governmental organization, so an NGO based in Portugal, who counts with the participation of 230 members. So associated people, and 64 workers and 52 volunteers. Our mission is mostly to improve coverage and access to prevention, harm reduction, early diagnosis and treatment service to tackle HIV, other sexually transmitted infections, viral hepatitis, TB, by enhancing the local community response and the key population participation on tailoring favored environments. So also P-lead service delivery, policy decision making, human rights advocacy, and second generation surveillance and granular evidence. So basically data on specific populations, specific contexts about the epidemics here in Portugal. Our areas of intervention are the effective prevention, the contribution to early diagnosis and access to health services and treatment adherence, universal treatment for everybody, stigma and discrimination, or fighting against stigma and discrimination, the production of knowledge, and the national and international advocacy in all these areas that I previously mentioned. So GAT counts with the 6 testing services, or as we also say, projects, and then we have 3 transversal services that give support to the projects. I can name the CAD, Anti-Discrimination Center, where we support ourselves to help our clients responding to situations where they felt discriminated both at health facilities or other contexts. The Love Condom, which is a service that provides condom, lubricants, and other information supports, and Para Par, or peer-to-peer, which is a peer support program that basically helps people navigating on the health systems. So it helps people getting in touch with the institutions and improves adherence to treatments and retention in healthcare. Other GAT initiatives are the CAB, the Community Advisory Board, the participation in the Fast Track Cities Lisbon, which are basically working in initiatives to tackle HIV, the Mais Participação, Melhor Saúde, More Participation, Better Health, which is an initiative that aims to improve literacy among the communities and to allow them to be active participators on the policy-making decisions. Also, Lusophone Network, which exists between Portugal and other Lusophone countries, and the Portuguese community-based screening network, to which we belong, along with other NGOs in Portugal. So basically, we report our screening activities to the Portuguese community-based screening network, allowing the network to collect important data and so as to have good information. So as I said before, we have different projects, and of course they have a common mission, which is providing a range of interventions tailored to the needs of different groups, but by offering rapid tests for HIV, hepatitis B, hepatitis C, syphilis, and medical and nursing appointments for other sexual transmitted infections. So this is the main goal of all projects, although then they have differences that naturally respond to the fact that they want to get in touch with different populations. So, for example, Checkpoint LX, it's a project focused in MSM, men who have sex with men, Intendente in sex workers, Gata Freak in migrants, mostly African migrants, in Moraria to people that use drugs, MOVs also to migrants and hard-to-reach populations, sex workers and their clients, and the mobile DCR, as I mentioned before, it's the drug consumption room, a mobile clinic. So all the interventions of these services aim to promote the prevention, diagnose, access to treatment and retention in healthcare, and all the treatment are absolutely free of charge, so no client pays anything. They are anonymous and confidential. We brought to you a very quick image of what happened in 2019 regarding the activities of testing and linkage to care in all GAT services. And so basically, as you can see from left to right, we performed a total number of 48,400 tests, then divided by around 17,000 of HIV, 15,000 of syphilis, and then 7,000 for HPV, and 8,000 to 9,000 to hepatitis C. As you can see, these numbers differ a bit. They are a bit different because for hepatitis B and hepatitis C, we have different criteria. And for example, for hepatitis B, there is a vaccine available in the national vaccination program since some years. So that's why these numbers are a bit different among infections. So from these 49,400 tests, we found 939 reactive results. These people were proposed to have a referral to treatment, and from those who accepted, 70% were actually referred to treatment. Besides referring a person that, for example, had a first reactive result in a blood rapid test, we also do other activities such as linkage to care and relinkage. So basically, linkage to care is to link somebody that was already connected to healthcare, maybe in a different hospital or maybe in a different country. So this we don't call a referral, but it's a linkage. In case that a person lost the follow-up with the hospital and then wants to get back in touch with that, eventually after being in a GET facility, if a person decides that she wants to get back in touch with the medical follow-up in a hospital, we can help the person doing a relinkage. And so these are the data regarding linkage and relinkage. As you can see below, we performed in all GET projects a global number of around 5,000 medical appointments and 8,000 nursing appointments and around 1,000 accompaniments or escorts to health services. So as I told you before, we also treat some other sexually transmitted infections in the GET facilities, such as, for example, syphilis or chlamydia or gonorrhea or others. So many of these consultation, medical or nursing appointments are also for those purpose, but of course for other purpose in general health. These 1,000 accompaniment to health services are part of that project that I taught you before, called par a par or peer-to-peer, the escort service to improve retention in healthcare and adherence to treatment and retention in healthcare. So there we were in GATT working until the COVID-19 epidemic showed up. This is more or less a global picture of the situation of the epidemic in Portugal at this moment. We brought you the data from the 26th of February to the 18th of May, which is, like 3 days before. I'm sorry, it's not the data from yesterday. But so in a global picture, we can see that we had around 29,000 confirmed cases in a biggest picture of 295,449 suspected cases and a total number of samples of 652,497. A global number of 1,231 people died, and 6,430 already recovered. As you can see in the picture that we brought to you, the epidemic and the numbers are more concentrated up north, with this north region being more affected, and in second place the Lisboa and Val do Tejo, which is the region that surrounds Lisbon, the capital. Up north was where the epicenter of the epidemic, the Portuguese epidemic, took place. So it's a little bit also about that, the distribution. These Açores and Madeira are the islands with a prevalence of cases at this moment too. So the Portuguese response to the vulnerable groups during the epidemic. From this response, we highlighted some measures, namely this dispatch from the government granting temporary residence rights to all immigrants and asylum seekers who applied for residence in the country before the 18th of March. So basically before the date where the state of emergency was declared. So these rights were given to immigrants and asylum seekers, and they were giving them access to social and health benefits, including access to the national health services, to bank accounts, work and rental contracts until at least the 1st of July of this year. So we don't know exactly how this will work, but for the moment, what we are doing is that we are helping our clients in these situations with literacy, allowing them to overcome the barriers that are still there to reach these benefits. For example, to get access to the NHS number or to other documents. It's not such an easy process. Of course, it's unfortunately a little bit bureaucratic. So basically, we are working on this base now. Other Portuguese response during this particular period of COVID-19 emergency period was to grant partial pardon to around 2,000 inmates that were released, and that represent around 15% of the total inmates population. These were people that had committed less serious crimes, with convictions up to 2 years only. And of course, then we need to help these people that were released to reorganize their lives outside the prison, and that's also part of our work. Therefore, they represent also some part of our some of these people are also our clients. Another measure was that antiretroviral therapy, antiretroviral medication start to be delivered at home or in community pharmacies instead of only in hospital pharmacies. This was a measure very well received by some of the people, and of course was taking place when accepted for the person, of course. During all this period and right in the beginning, even before the emergency state was declared by the state, GAT start to prepare a contingency plan, thinking about how will we organize our services so that we can keep providing care to the people that seek us. So basically, we elaborated a plan according to the National Health Directorate for the COVID-19, with their guidelines, and with the main objective that actually is also one of the main objectives of the Ministry of Health, which is to contribute to reduce the number of the community cases of COVID-19 in order to avoid exceeding the capacity of the NHS to respond to this epidemic context. There were some general security measures adopted in GAT services to reduce the risk of transmission between both employees and clients, namely to reduce the circulation of people in closed settings, both for clients and staff, by dividing teams, by rescheduling shifts, by organizing circuits for clients to get into the facilities, the number of people that could be inside places, etc. And of course, by updating the cleaning and disinfection norms. That was also an important aspect. Other additional measures to avoid the local transmission between employees and clients were adopted. Redesigning the testing spaces, introducing the PPE or personal protective equipment, both for clients and for staff, and always, of course, according to the NHS guidelines. By screening COVID-19 symptoms before providing services in closed settings, but when admitting people into the services, simply by measuring temperature and by performing a flash questionnaire on the COVID-19 symptoms and signs, and inviting people to disinfect the hands with a hand sanitizer. Also reorganizing the space, avoiding having too much furniture, too much things into the over the surfaces. Helping simplifying the whole process of disinfecting the spaces. Some indications toward the employers at more vulnerable or greater or at biggest with a greater risk of exposure. Also, we promote some health procedures on how to prevent, to identify and act regarding COVID-19, and we provided health literacy both among staff by sharing also via email several documents with information regarding this, sharing materials to have in the services, and by contacting our patients, our clients, assessing them on how they were dealing with this epidemic, most specifically those at more vulnerable situations. We also worked right at the beginning in having a very clear protocol with the descriptions of the security procedures to be followed in case of the suspected or confirmed cases of COVID-19 in our facilities. So although people are screened in the enter, in case this could happen, we had and have all the protocol about how to deal with this situation, where to conduct the person, how to be in contact, how to isolate this person and avoid the other contacts, and how to help the person getting in touch with the NHS helpline through the helpline. And yes, so basically these were our work. This is a resume, a brief resume on how it is the contingency plan. So I'm glad to say that during the Portuguese state of emergency, all centers ensured minimal services, providing HIV, viral hepatitis, and syphilis rapid testing when booked, mostly. Nursing and medical appointments, prioritizing symptomatic patients and clients without access to healthcare, namely this population of immigrants without access to the NHS number. And here I can say that if you do not have access to the NHS number, the way in which you have access to care changes a lot, namely regarding the fees. So you pay higher fees, which for a migrant person, which is frequently in a vulnerable situation, represents a barrier in the access to healthcare, and can so be, well, that's it, a barrier. So during the contingency period, we kept also the activities of sexual counseling and referral to healthcare and social services, mostly through telephone contacts, and the distribution of condoms and lube and, of course, needles and syringes. So now what we see is that with the end of the emergency state at the 3rd of May, so this month, it's very important for us to continuous assess to assure the access to such services, as the civil society and the communities play a critical role in reaching this key population and vulnerable groups. As you can imagine, we work with people in irregular situations, so undocumented people that frequently are afraid of getting in touch with the institution. We work with people that use drugs, that frequently feel stigma and discrimination, so are not in touch with many services. So these kind of services are very important to reach these key populations. We now realize that the key groups and the people living with HIV have been underrepresented among the cases of coronavirus disease, even in locations and contexts where the prevalence of HIV is high, or when the prevalence of the coronavirus infection is high. Therefore, we think that studies can help elucidate and contribute to the knowledge in this area and are much needed. So GAT applies for funds to investigate in the area of estimating the prevalence and determinants of SARS-CoV-2 among key groups at GAT centers, integrating the offer of rapid qualitative tests for IgM and IgG, and the impact in the stigma, violence, and living conditions. Also, we would like to investigate in the area of assessing the prevalence and the effect of the clinical course of SARS-CoV-2 infection in people living with HIV or on under antiretroviral therapy. To assess the to refer the people with IgG positive rapid tests for them to have access to study their immunity to COVID-19. And also we realized, well, we already knew, but we had another contact with the situation, that is that with the reduction of the healthcare provision in the national health system, people with lower health literacy are more at risk of not using such services. And therefore, to promote the health literacy and easier strategic navigation services in NHS and of course other services like social services, it's very, very important to avoid that in such situations like this, where access to resources is already limited and more difficult, that these people that have lower health literacy suffer even more and reach even a lower contact with institutions. So that's it. Basically, this is how we managed to keep our services working during the COVID-19 epidemic, and we still work. I'm very glad that I could share these small results with you. I hope, I wish to you all that you be safe.